competence without compassion is meaningless. And when I looked at the data, there was clearly an increased error in targeting accuracy. So we said, well, which target is better? So each patient actually had 4 of these electrodes put in. And perhaps one of the things that blew me away, not just about the patients, but about the science behind it, is that that particular trial, the question that was outstanding for us when we came to this.
Welcome to Stimulating Brains.
Hello and welcome to Stimulating Brains. My guest today is Ludvic Zrinzo, Professor of Functional Neurosurgery at UCL and Head of the Functional Neurosurgery Unit at Queen Square in London. Ludwig is a neurosurgeon who has shaped how we think about precision and evidence in functional neurosurgery, from deep brain stimulation for movement disorders and psychiatric disease to lesioning approaches and emerging adaptive DBS paradigms. Ludwig is well known for many things, but maybe also for his work on target selection and comparative trials in OCD, including a rare randomized within-patient comparison of ventral capsule, ventral striatum versus subthalamic stimulation, and his broad contribution may also be in asking what works for whom and why. Today I'm looking forward to discussing his career path, his view on DBS versus lesioning, adaptive stimulation, and where functional neurosurgery is heading next. I personally had 2 separate moments with Ludvic Zrinzo early in my career, when he said 2 simple statements, which both transformed how I thought about DBS going forward. So I'm pretty sure there's something in this conversation not only for the seasoned and experienced DBS researcher or clinician, but maybe also for people starting off into the field, because the clarity of how Ludwig thinks about these concepts that we all deal with is, I think, truly outstanding. I hope you had a great start into 2026, and thank you for tuning in to Stimulating Brains. So Ludwig, thank you so much for doing this. It's really a big honor to have you on the show. You have been on the first speaker in our talk series as well, which was a fantastic talk. Unfortunately, it wasn't recorded, but I really enjoyed that, and it's a big pleasure. We've known each other for a while now. It's always really fantastic to pick your brain. You've said so many wise things in the past that I've really profited from, even though you might not be aware of that. And it's a big pleasure to talk to you. So thank you for coming on the show.
Andy, thank you for having me. It's, as I say, it's always a pleasure to chat with you, and it's been a while since we caught up in person properly like this. So thank you.
That is true. So yeah, I think, or you might know that the first question is always about hobbies, to just break the ice. So if you're not operating, not in the theater, as you guys say, or not doing research, what do you do for fun these days?
Well, I must admit, I've become quite an aficionado for exercise, for physical exercise. So I don't know if you've heard of Peloton, which is this app and training app that you can have. And around about COVID time, for once in my career, I had a little bit of time that I didn't know what to do with. And I decided to look after myself a little bit. And I started exercising, and it became a really important part of who I am now. And maybe I came to this idea quite late in life, which is surprising since the time of the Greeks and the Romans, mens sana and corpora sana, they say. But I didn't take that on board until quite late. And this is my time. When I exercise, that's my time. That's my time to work through things that are in my mind, subconsciously, sometimes consciously. My time to get some natural endorphins going, my time to distance myself from what's going on in the world of work, if you like, or in other spheres. And I won't say that I'm very good at it, which is perhaps the important thing. The fact that I'm not out there to be the best there is. I'm out there
Sure.
just for me.
Yeah.
So that's one thing that's really important for me. And then outside of work, my family. So spending
Yeah.
time with my wife, spending time with my children, my daughters, spending time with the wider family as well, and with friends. I'd like to have even more time about that, but I think life-work balance is a problem for every doctor on this planet.
Yeah, yeah, yeah. I'm sure, especially neurosurgeons, maybe, but yeah. Okay, so you grew up in Malta, which in itself is interesting, right? Different than I would say many countries. It's an island. It's smaller than many countries. And I remember also your father was a famous doctor there, and maybe even local hero or something, if I remember correctly. And if I recall correctly, you once said that growing up you didn't want to become a doctor, but then there was some happening that changed that. Is that correct? Could you maybe talk a bit
Oh,
about that?
so Andy, I think you could probably tell the story yourself, but I was actually born in the UK because both my parents are doctors,
Yeah.
and my father wanted to become a neurosurgeon. There was no neurosurgeon in Malta, but unfortunately there was no neurologist either. So he had to take the long route and first trained in general medicine, then trained in neurology, and then trained in general surgery because that's what you have to do, and then trained in neurosurgery. So you
Wow.
can imagine the breadth and width of knowledge of the old guard, if you like, of the neurosurgeons that came before us. And my mother wanted to be an orthopedic surgeon, but when I was born, realized that two surgeons in the family just wasn't going to cut it. So she did radiology.
Yeah.
And then when CT was introduced and MRI was introduced, because that's how long ago we're talking, they realized that actually going back to Malta without a radiologist who could help was going to be tough. And so she trained in neuroradiology. So they went back as a neurosurgeon, neuroradiologist couple at that time doing myelograms and then later on MRIs. So my father was the first neurosurgeon in Malta.
Wow.
And he was the only neurosurgeon in Malta for over a decade.
Yeah.
So I went to Malta when I was 10 because the family went back. And as you say, Malta's a tiny country, but I
Mhm.
loved it. I loved growing up there. The weather was always good. I could get on my bike and go around the whole country, jump in the sea whenever you wanted
Yeah.
to. It wasn't so built and busy as it is now. So growing up was wonderful. I admit to being a bit of a nerd. I really enjoyed my physics and my maths.
Mhm.
And I hated my father's job because I never saw him. There was no way you
Mhm.
could convince me to be a doctor, let alone a neurosurgeon. There was absolutely no plans for me to go down the same sort of route until there was a epiphany, if you like. I think I was probably 14 at the time.
Mhm.
When on my way to doing engineering or maths and physics or astrophysics, I hadn't decided how I wanted to use my maths. Um, but there was a hijack and PLO terrorists at the time hijacked this Air Egypt plane and forced it onto the tarmac in Malta. Malta had no army to speak of, and it was a huge international tragedy at the time, not only because of the terrorist situation, but because there were American citizens on that plane, there were Jewish people on that plane, of course, Arabs on that plane, in an Air Egypt plane on Maltese soil. And because of the international problems with law, they ended up getting Egyptian commandos to storm the plane. But before they did that, the terrorists were shooting the hostages in the head every hour
Oh my
and
God.
throwing them out of the plane. My father disappeared, as did all the country's doctors, for a few days into the hospital, and he came back a few days later with a beard, having operated on three of these patients and saved their lives.
Wow.
And I thought, as maybe even now as an adult, it's pretty impressive, but definitely as a 14-year-old kid being shot in the head and doing something to help them survive was. And there was another thing to it. I think when I was that age, again, it was a long time ago, Andy. There was no 24-hour news. The internet was just starting.
Yeah.
And for me, this sort of inhumanity of one person to another, how you could kill somebody in cold blood, somebody
Yeah.
you never met before today, just because of this religious or political ideology that you held, I thought that belonged in the Middle Ages. I didn't think
Yeah.
that people were still that awful to each other. And more than the scientific marvel of being able to save someone's life after being shot in the head, I think it was the humanity of actually dedicating your whole life to being able to be in a position to help someone when they're at perhaps the lowest ebb they possibly can be. Um, and later on, far later on, I think I'm not sure if you know of Albert Roton. Albert Roton was a famous American neurosurgeon
Yeah.
who drove micro neurosurgery, and
Yes.
perhaps the most important part of his neurosurgical book was in the foreword. And in the foreword, he actually says, competence without compassion is meaningless. Of course,
Interesting.
compassion without competence is useless,
Yeah.
right? So you have to have both. And I think it's a real measure of maybe the pinnacle of humanity, so that we have evolved a society that allows people like you and I to study for decades, to put us in the position to help those when they're at the lowest ebb of their lives. And I think that is a very sobering thought. And needless to say, at that age, I probably didn't think through it in such a fashion.
Of course. Yeah.
It made me change my mind, and much to my father's disappointment, because he was really quite keen that I could do mathematics.
Oh yeah.
Yeah. Well, I think he'd reached
That's rare. Normally, people would want their children to follow the footsteps, or they would
yeah.
be honored. But yeah.
I think there is a part of him that was
Yeah.
pleased, but there was the other part of him where I think when you're the only neurosurgeon and
Yeah.
you're on call every single moment, at some point you start saying, "Do I want to inflict this on my
Of
children?"
course.
Now,
Yeah.
clearly he hasn't, because things have evolved, and I'm very fortunate to be one of 30 neurosurgeons at Queen Square in London. So I'm not on call every day, far from
Yeah.
it. Although I was on call yesterday,
Okay.
um, but yeah, that's the story of my growing up in
Fantastic.
Malta.
A bit of a jump here, but you have also started operating in Malta, maybe even recently, a few years ago or a decade ago,
No, so,
maybe or so
no,
as well.
it's been quite a while actually
Okay.
now since when I became a consultant in the UK. Malta's,
Yeah.
for those listeners who don't know, Malta's a tiny little country in the middle of the Mediterranean. It's only 21 miles by 14. Yet it's very densely populated. There's
Mm.
600,000 people at the last count, and the population's increasing rapidly because of immigration. And because it's so small, it's very difficult to subspecialize within
Of course.
neurosurgery. So at the
Yeah.
moment, there are three neurosurgeons now, which is luxury compared to when I was growing up there. But you can't really subspecialize. So when the beautiful thing, I'm very proud of Malta. I mean, I'm genetically Maltese, and they are still a very left-wing country in the sense that healthcare is completely free. Going to university is completely free.
Right.
They support the youth, and rather than put them in debt, as many modern countries do. And when the techniques aren't available in Malta, or they send people abroad, they send patients abroad. So when I became a consultant almost 20 years ago, the Maltese government said, "Oh, can we start sending patients to you in the UK?" And I said, "Yes, sure." So I started operating on Maltese patients in London, which again
Yeah.
was a privilege. But the numbers started to increase and increase and increase. And at one point, when I went back to Malta, the prime minister at the time called me and said, "Would you mind operating in Malta?" And I said, "Well, listen,
Hmm.
if we have the equipment and we train the staff, of course." So it started from maybe 15 years ago. There was a young girl with dystonia.
Yeah.
It was a genetic type of dystonia. She was very extremely disabled. And rather than transport her to London, I went and operated on her in Malta. And again, it's a nice story of humanity. We hear so much bad news, but I approached Electa, who made the stereotactic frame, and said, "Would you mind sending us a frame that we can use? And can you donate it and we'll pay for shipping?" And Electa said, "Absolutely, but we're going to pay for shipping," which was
Wow.
lovely of
Okay.
them. And the only DBS company at the time was Medtronic, and I said, "Was it possible to give up the leads at cost price because the government isn't paying for it yet?" And they said, absolutely not. We're going to give you a set. And they
Wow.
donated the hardware. And it was just so lovely to see different companies in different countries coming together. And this young lady who I operated on when she was 3 is now in her early 20s. She's still disabled, but she's managed to go to university. She's managed to get a degree. Without when the DBS is off, she can't communicate because she's a communicator for this, and she can't move her wheelchair.
Fantastic. Yeah.
And she can. So it's just a lovely story of humanity pulling together to help
Yeah.
disabled.
Wow.
It's
That's
become a
great.
little, yeah, it's become a little bit too successful because I'm in Malta almost every other month now,
Okay.
operating on patients. But it's good. I get to see the local team, which is nice, and
Yeah.
they can feel a bit isolated when you're in a small country. So I think coming and looking at things from a different angle is really nice. And I feel also, again, I did medical school in Malta. I didn't have to pay. I wasn't saddled with student loans, so I feel quite indebted to society over there. And this is my little way of giving something back as well.
Oh, it's not a little way, but it's a lovely story. I mean, it also helps you, of course, connect to back home. But I would I would assume you already have a very busy job in at UCL alone. So doing this on top is, I'm sure, not. It's a
It's fun.
commitment. That's fantastic. Yeah. So how you did med school in Malta, but then also built your career at Queen Square UCL. What was the key moment when you decided functional neurosurgery is for me?
Well, again, being a young neurosurgeon in training and having come from the story that I told you, of course, you want to do the big guy stuff, right? And the big
Sure.
guy stuff is clipping aneurysms. That's what
Yeah.
you should be doing, you know. High stakes, high adrenaline, all of that. In your youth, that's what drives you. Um, However, when I first came to Queen Square, they had started coiling aneurysms.
Hmm.
And I was fortunate to see patients who had had coiling and who had that clipping. And clearly, coiling was much less traumatic. Clearly,
Hmm.
if you can avoid opening the head or disturbing the brain, then that makes a lot of sense. And as a doctor, when you're young, you think about yourself. When you're a doctor, you think about your patients.
Yeah.
And clearly, the writing was on the wall for clipping. So vascular became less of an interest for me, and I put my heart, funnily enough, into pediatric neurosurgery. I was
Okay.
really keen on pediatric neurosurgery um, until I found out that it was emotionally such a huge roller coaster. It was,
Oh, I'm sure it wouldn't be for me.
um,
Yeah. Yeah.
and it was long hours. I loved it when everything went well, and of course, things don't always go well. And it was a huge. I'm very. In Maltese, we have a saying, "Albeg Junglina," which means your heart is like a sesame seed. You cry easily,
Yeah.
and it was emotionally very difficult for me. Hats off to the pediatric neurosurgeons who are good friends. But I think the tipping point, as in many people, was meeting the right people. And it was Marwan Haris and Patricia Limazan who just were an amazing neurology and neurosurgery team that were totally focused about the patient and totally committed to safety and to good outcomes, as well as using that opportunity to explore the human brain, which is this amazing lump of mush that we have between our ears. Now, of course, functional neurosurgery drives our understanding of the brain forward in small degrees, but it does mean you have to think about it. With most of neurosurgery, it's about avoiding the eloquent areas, about
Yes.
avoiding damaging. Functional neurosurgery is slightly different. You have to try and understand what the brain actually does and
Yeah.
how pathology affects it and how you can medically or surgically modulate that
Yeah.
abnormal activity. So I think the academic aspect combined with the humane or humanity aspect of it in such a multidisciplinary, it wasn't lip service. This was a true multidisciplinary team, co-locating neurologists, neurosurgeons, speech and language therapists. It was just specialist nurses. The whole approach really spoke volumes to me. And when I started doing clinical research, starting with just simple audits and then applying the results to clinical practice and seeing a change, seeing an
Yeah.
improvement, that for me was very rewarding. It wasn't just treating individual patients, it was about changing the way we treat a whole group of patients.
Fantastic. And you mentioned Marwan already. Next question would be on mentors. And I did in preparation email him whether there was a question he always wanted to ask Ludwig and didn't dare to. And of course, he said he asked you millions of questions and he dared to ask everything he had on his mind. So there's no question from Marwan, but he of course praised your work and your colleagueship and so on. I'm sure he was very important mentor for you. Are there others, and do you want to speak a bit about
Well,
your
I won't go
relationship
on.
with him?
I won't go on to others before I've nodded my head to
Yeah,
Marwan. I mean,
yeah,
Marwan, as we all know, is just one of those amazing people who knows your papers in more detail than you know them.
that is
I
true.
mean, he reads absolutely everything, and reads critically. And he wasn't, although he was clearly my mentor, he wasn't too full of himself to change the way he sees things. He was always
Mm,
open to new ideas, whether it was about small things like shaving patient's head, which he did and then changed, or whether it
yeah,
was about big things, about moving from awake surgery to a sleep surgery, or moving from, again, my life is littered with examples. And when things didn't go well, as sometimes they don't, he was so keen on examining every single angle of what went wrong to make sure it doesn't happen again, to try and understand why we can improve things. And I
right.
think that dedication was great. And I'll move on to Patricia. I mean, Patricia Lemazan is just it's such a privilege to be able to work with her to this day. The first person to ever switch on
Yeah,
STN DBS, right? This is what more could a functional neurosurgeon want than to work with a slice of history, right?
yeah,
And once again, she's so patient-centered, and I think that's the crux of what I think I love about both of those two great mentors in my life. I've had a number of other mentors along the way, not just in functional neurosurgery. And
yeah.
sometimes you learn things from people and you say, I don't want to imitate that. I don't want to do that. Those people will go nameless. But then the others, so Neil Kitchen is a neurosurgeon he's not a functional neurosurgeon, but he was a great mentor in surgical technique, teaching me that actually the important thing is to do less. Neurosurgery, nature actually does a pretty good job, and we're
Hmm.
just nudging it in the right direction. And sometimes a smaller operation or a smaller approach, focusing on just nudging things in the right direction, can be much more effective and most importantly, less risky.
Yeah,
Than going, doing the big thing that looks impressive on imaging, but
yeah.
isn't necessarily the best thing for the patient in
Yes.
practice. So yeah, I mean, I could go on and on and on. I've only just come back from a month sabbatical in Shanghai,
Oh, wow.
where I shadowed neurosurgeons over there. I have a particular interest in microvascular decompression, and I was there with a gentleman called Dr. Lee, who's published extensively on this. And it was just a joy, even at this stage in my career, to share knowledge with people like that. So, and of course, at the end of the day, I think the ultimate mentors are our patients, right? You learn
Yeah.
so much from each and every patient, particularly when things don't go the way you'd like them to.
Mhm. Yeah, well said. Fantastic. You became head of the UCL functional neurosurgery unit when Marwan left. What now? 3, 4 years ago? Time
Oh
passes
gosh,
quickly. Around.
2018 already.
Even so. Oh, time flies. Okay,
Time
7 years
flies.
ago. Um, and what changed in your day-to-day thinking once you maybe now were the person ultimately responsible for outcomes, but also strategy, training, the new generation, all these things?
So again, I think I'm going to have to start with another quality that Marwan has as mentor, which was not to hang on to everything as a leader. He was so generous at giving not just knowledge but also responsibility. So
Yeah,
for me, it wasn't a cliff edge. It wasn't like now everything's on your lap. Bye bye. It
yeah,
wasn't like that at all. Over the years, he sort of given me that, okay, audit is kind of, you're clearly good in this, lead on it. Right. working with management at hospital, you're clearly good at that, lead on that. So it was a very seamless
Right.
transition, really. And again, I don't, although you call me the head of, functional neurosurgery, I don't feel very hierarchical. I think
Mm.
I'm just really fortunate that we've organically grown as a unit. And I've got some, like, how can I say that I'm the head of Patricia Limousin? Of course I'm not. We work together towards that. You may
Yeah.
know Tom Faultini, who's another world-renowned neurologist
Yes.
who isn't just known in the world of functional, but also in terms of disease-modifying therapies and
Yeah.
large trials to try and understand the pathophysiology and the pharmacology of medications and the evolution of Parkinson's disease. Um, the other surgeons I work with, Harith Akram, Johnny Hyam, and of course now Marie Kruger, again, it feels so much like a team that it's not difficult to lead the group because we all push and pull the group in the direction that we want it to go.
Yeah.
So yeah, I didn't feel like it was a cliff edge at all because we're such a cohesive unit.
Yeah. And then I remember, I think even earlier than that, around 2017, we invited you to Boston. We had a small meeting there, and you already very vividly fought for also having Harith Akram join this. And you wrote something like "He's the future." And I also asked the younger generation now for insights and questions. And I think one that came up was indeed that you already think about succession, right? That is an ingrained thing. Might have come from your own mentor a bit, right? But do you,
Totally.
because not everybody does that, right? And so what's the secret in already building into, your career, also thinking about succession, making sure the next generation of leaders comes? Do you have some words on that?
Well, I think it's silly not to. I mean,
Yeah.
why would you want to? Why would you want to hold on to everything and then when you retire, you've lost everything, I think.
Hmm.
If you want a legacy, if that's even a word,
Yeah.
the right thing to do is to grow the people around you because you grow more by comparison. And you're quite right. Marwan was amazing at promoting his junior staff. We used to go to international meetings when I was a young registrar, and
Hmm.
he introduced me to Andres Lozano as his teacher. Marwan said, "Ludwig is my teacher." I'm like, "Come on." But
Yeah.
like you're quite right. How many people promote their students in that way, and it makes you feel very proud, of course, but it also
Hmm.
makes you confident. And I think lack of confidence sometimes comes through in people who aren't ready to promote people around them.
Yeah.
And let's face it, the professor of physics, I think in Cambridge, resigned at one point to give his chair to Isaac Newton, saying this guy is a much brighter guy than I will ever be.
Wow.
I think that's everybody praises Isaac Newton, and the name of this professor who resigned his chair escapes me, unfortunately.
Hmm.
But clearly, there is some greatness in that. I think that being able to recognize the talent and to work with the talent around you is exceedingly important. Yeah, and not just in your own institution. Again, Andy,
Yeah.
you are the master at bringing people together in collaborative research
Thanks for
programs.
saying that. Yeah, I mean, for me, that is what makes the whole thing so much fun as well, right? The interaction with others, and I mean, I'm still, my first generation of scientists that went through the lab just left the nest, so I can't speak to it, but I still, I've talked to people along the years, and I felt many people said that exactly this seeing other people grow that may have, started with you is such a rewarding thing, isn't it? I mean,
Totally.
yeah. Okay. So, looking back, the other direction, what early career mistake may you have made that maybe now made you a better functional neurosurgeon?
That's a really good question. Well, I've got a few, and it's difficult to choose. But I'll start with yet another example. I mean, back in the day, we didn't have all the fancy software to plan your surgery and plan your targeting, etc.
Mhm.
And we used to use Axiom and coronal images. And I remember Marwan having this backlit display, and we would print out the images and put them down and measure with a little pin and mark mark the stereotactic scans. And then when we came to the trajectory planning, he'd get a coronal scan and make sure we avoid the ventricles. But of course, that's not the angle that you actually are taking, because
Yeah.
you've got a double oblique. It's not through a coronal. And at one point, he trusted me enough to do this on my own. And clearly, I plotted wrongly, and I ended up putting my burr hole a little bit too medially. And we went through the ventricle in this gentleman. And when we got a post-operative stereotactic MR, our lead was 3.5 millimeters off, which was way more than ever we had an error in. So we ended up taking the patient back to theatre, readjusting the burr hole and the electrode, got it spot on. But I remained quite haunted by this. And I was looking through the literature, and there's absolutely no record of whether the ventricle was useful, you should avoid it or not avoid it. And when I went to the next ESSFN meeting, Marwin told me, you have to come to this meeting, all the big people are there. I actually went up to the big names in the groups and said, oh, do you mind going through the ventricle or not? And some of them said, oh, it doesn't matter if you go through the ventricle, it's all fine. And some people said, we never go through the ventricle. But two people stood out, and one of them was Antonio de Sales, who was at that time professor of neurosurgery at UCLA. And he said, oh, we go through the ventricle, no problem. And I said, but do you have the stereotactic coordinates of where you want it to be and the images post-op? And he said, yeah, we have them. I said, if he actually looked at them to see what the accuracy was like. And he said, no. I said, can I come and visit? And he said, yeah, come and do a fellowship at UCLA. And then the other person was Michael Stahl, who unfortunately is now passed in the Netherlands. And he said, oh, we go through the ventricle all the time. We have all that data. And these two very senior, very well-respected neurosurgeons allowed me to gather their data, look at their data. And when I looked at the data, there was clearly an increased error in targeting accuracy when you went through the ventricle compared to when you didn't. So, and that ended up being a publication, one of my earlier publications. But again, I think it laid the example. It's a very good example of how when things go wrong in clinical practice, and things didn't go hugely wrong in the sense that the patient didn't come to harm, but it established the fact that we try not to go through the ventricle if we can. Now, of course, sometimes when you're doing anterior nucleus of the thalamus, DBS, you have to, but and I think the angle of approach is different. When you go through the anterior nucleus, you're going quite orthogonally. So that's one example. And then from my general neurosurgical time, I remember being very aggressively taking out a posterior fossa tumor and causing neurological harm to this patient. I must have hurt the dentate and this patient ended up with a rubral tremor, essentially, because it was further back. Little did I know that a few years after this was when I was a trainee, and it really taught me about the importance of thinking about the patient rather than the pathology. And the patient's more important than the pathology, right?
Yes.
But as a young doctor, sometimes you don't think those ways. Little did I know that later on I'd be able to help her by helping her with getting rid of the tremor.
Oh, interesting. Yeah.
I wasn't even functional neurosurgery. This was a long time in the future, and I also learned how amazing human beings can be, that this lady actually trusted me to try and help her after I'd caused her harm, a decade before. But there you go.
Really, really great examples. Thank you for sharing these. Your work, it's hard to talk to you and not talk about, MRI guidance and maybe also sleep DBS. Your work repeatedly emphasizes this accuracy, safety, and image verification. I think the London Center had been really pioneering this with Marwan and you leading, the shift from, as you mentioned, also awake DBS to a sleep DBS. What do you think actually moves the needle in real-world targeting accuracy today? So, better imaging. Sometimes I'm surprised how bad the quality is of pre-op imaging in some centers. And then better planning, better frames, robots, physiology. What really is key these days?
So for me, the key is imaging, right? I
Mm.
mean, we have this. This is such an amazing tool, right? We can see the living human brain in
Yeah.
phenomenal detail with this tool that's freely available in every hospital that we work in now. This isn't a
Yeah.
rarity anymore.
Yeah.
And what really amazes me is, as you rightly say, sometimes the quality of the imaging is so poor.
Mm.
And I just think we really need to engage with our radiology colleagues, with our MR physics colleagues, because they are an integral part of the team. You know, we talk about functional neurosurgery being the multidisciplinary team per excellence. But how can we improve the first pass that we make? And
Mm.
none of the other things that you talk about can improve the accuracy if the imaging isn't good. If you can't see your target, how on earth, with the most accurate tool in the universe,
Yeah.
your first pass isn't going to be on target if you
Yeah.
can't see it? So I think imaging is totally key, and it's not just about field strength. You know, I think even with a 1.5 Tesla magnet, you can get really good images that allow you to see the common targets that we use. Now, of
Yes.
course, 3T is even better, you know, and it's lovely to have a 3T machine. But at the moment in Malta, I use a 1.5T and get really good results, clinical
You know
results.
what? When we got the 3T at Charity, the imaging got worse by far. And
Because
then
we
we had to
we
adjust it again,
improved
right?
it.
But
Yeah,
it was such good. The 1.5 images were super good actually.
yeah, yeah, yeah.
They were
It, it,
great. They
it,
were,
it's
yeah.
not about field strength, just about
Yeah.
field strength. It's a
Yeah.
lot about the sequences that you use and the coils that you use. And yeah, so I think the answer to that is, of course, everything is important. Every step in the stereotactic procedure is important, but it starts with imaging. And
Yeah.
it ends with imaging, because at the end of the day, you can plan till the cows come home. I always give this example to visitors. If you're a Olympic archer and you're trying to get better and you want to win the tournament, you don't practice and then walk away from the target board. You go and see where your arrows ended
Yeah.
up. So that if there's an error, you try and correct it. And that was Marwan's philosophy from the beginning. And all I really did was systemize it. So I looked at this in a very, I ordered it in great detail and great accuracy. And again, we came from a point of clinical practice where there were some patients who just could not have surgery awake. The bottom line was, the traditional way to do this was awake surgery. There's some patients who, you took them off their medication, they couldn't breathe, or they had so much chronic pain that there was no way they were going to sit through this operation. And when I looked at the clinical outcome of these patients who had had surgery asleep, where we relied just on the imaging, the outcome was better, significantly,
Mm. Wow. Okay.
both in terms of clinical outcome, both in terms of length of stay and in terms of complications.
Yeah.
And when we took this data to Mo and we looked at it in our research meeting, he said, "Yeah, you're right. You know, it was sometimes we were actually fooled when we were doing awake surgery. We had a really good result on the table,
Mm.
but then we imaged the patient and the electrodes weren't, they were a bit medial to the STN. And this is 25 years ago. I'm talking about 20 years. And we accepted that because the results on the table were good. We had good LFPs, but the patient was much better. But then 1 year later, the speech wasn't good and we weren't
Mm.
getting the expected UPDRS. And then we relocated the leads under general anesthetic. And this patient was doing brilliantly. So we're
Mm.
actually fooled by testing under local anesthesia to leave poorly anatomically placed leads. And then we dispensed with the local anesthesia completely. And as a result, now when we do deep brain stimulation, we do them under general anesthesia. The result is we don't have to take patients off medication, which patients love.
Yeah.
It is quite difficult for patients undergoing
It
surgery
is.
under local sometimes, especially when they've got advanced PD off meds. The surgery is much shorter.
Yeah.
We tend to operate in pairs, which I think that's really good because human error is there. So we always check the frame with each other and whatnot. When we're operating with Marie, we do this routinely in under an hour. You know, both sides and the battery. So
Wow.
infection has become really rare because the length of surgery does correlate with the infection rate.
Of course.
Everything's better. We can operate on more patients. You know,
Yeah.
sometimes, quite rightly, in the world of functional neurosurgery, we obsess about getting a 65% improvement in UPDRS3 rather than a 60% improvement, which is
Mm.
important. But if you operate on two patients, in the same time that you operate on one patient and get them to a 60% improvement.
Yeah.
Isn't that even better?
No, of course, yeah. And
So,
I mean, you mentioned people, the outcomes were even better on asleep. Was that probably because less brain shift, do you think? Or because it
yes,
took, or what was the main driver
well,
for that?
I think
Or
you're
did were you fooled even by EFIS to change to,
Yeah, so I think you've hit the nail on the head, Andy. The
okay.
first is that when patients are asleep, they have positive pressure ventilation, so you get less CSF loss,
Mhm.
you get no
Okay.
brain shift, so you're more accurate in terms of your targeting. But there is also the fact that some patients slip through the net when we did local anesthetic because we didn't change a suboptimally placed lead because we got good clinical benefit.
But
And
how do you, so maybe it would be worth it to even briefly summarize your procedure, because you didn't just do image guidance, but also image verification as a really critical new thing, right? So
totally,
you do
totally.
post-op MRI with the frame on, is that correct?
So this back then, when we made the shift, we did a post-op MRI with the frame on in every single patient, and
Yeah.
that was purely Marwan's insistence that I want to know where I am compared to where I wanted to be, which is a very reasonable thing. I remember having pitched battles with MR at the time, right?
Mm.
And back then again, his justification was that doing a post-op CT, you couldn't see the lead, you couldn't see the you could see the lead, but
But not the,
you
yeah.
couldn't see the anatomy. And when you have brain shift, which was not rare at the time,
Mm.
your anatomy's changed. So you might
Yeah.
be in the right stereotactic coordinates, but in the wrong anatomical target. So
Yeah.
he insisted on MR because you could see the lead and the anatomy. We have changed over the years. So now actually we do a post-op stereotactic CT.
Yeah.
And the main driver for that has been that we don't have any intraoperative air anymore. So there is no shift. So the main reason for doing an MR has changed. And of course, with directional leads, you're going to do a post-op CT anyway, because you want to see
Yeah.
where the directionality is. Of course, it's quicker, and it helps us drive workflow. So there's a number of reasons why we've moved to a post-operative stereotactic CT. But the bottom line is, in my practice, you haven't finished the procedure until you've documented where the leads are. And
Yeah.
I think that's just a really important principle. If you've clipped an aneurysm, you put dye through the vessel to make sure that the aneurysm doesn't fill and that
Yeah.
the distal vessels fill. You want to check that you've done the right thing before you finish the operation. I think it's a fundamental principle.
Of course.
And I'm sure you're aware there was a paper a few years ago from the States looking at revision DBS procedures. And almost half of the revision DBS procedures were because the leads were in the wrong place.
Mm.
Which, if you bothered to get stereotactic imaging during the first procedure, that wouldn't happen.
Yeah. And you said before that when you were doing awake, you would sometimes accept poorly placed leads on the imaging because you knew the effect was there. Is that
Well,
correct? Or
again, this isn't the beginning of DBS.
yeah.
This is 25 years ago. We're talking.
No, 100%. But
We put the leads in, and we had a fantastic result in
yeah,
terms of DRS improvement, in terms of stiffness and tremor and whatnot. No side effects. And
yeah,
then we'd noticed that the lead was too medial. It was medial to the STN. Not terribly placed, and some
sure.
of the top
No.
contacts
Yeah,
were within the STN, but not perfect, right?
yeah,
But we didn't know that at the time, right? We only know that
yeah.
now because we've gathered prospective data,
Of
and
course.
and now we all talk about these sweet spots and sour spots, and this is what we've built. This is how we built
Yeah,
towards the sweet and sour spot. So, of course, every procedure has its time, and I'm very glad we went through this learning curve because I wouldn't know where to place the leads on the imaging if we hadn't made these errors. And this is going back
yeah.
to what I'm talking about. What is it?
No, it was more for me to understand why the pure imaging ones might have been better, and I'd like the
Yes,
checking. So that just to close that loop, right? And that's a
yeah,
really important point, actually, right? To if you're fooled by the intra-op
clinical.
stim, yeah,
And don't forget, when you're doing imaging, the only thing you have is the imaging.
yeah,
So you can't say, "Oh, the patient's doing well." You say, "Well, my lead is 1.8 millimeters away from where I wanted it to be,
yeah,
and I can make it better."
yeah.
And because your lead is there, you now have an internal fiducial marker. So all you have to do is say, okay, wherever I aimed, if I'm 2 millimeters medial and 0.5 millimeters anterior, well, I'm going to put 2 millimeters more lateral on the X and point, and we put the second lead in before we take the first lead
Oh,
out.
cool. Yeah. Yeah.
So that, and the second lead is always bang on target then.
Of course. Fantastic. Really cool. Okay. And what are the most common hidden failure modes in DBS surgery that maybe don't show up in papers? So what I often, as a not a surgeon, wonder about is frame accuracy, or are there other things? Oh, and maybe relatedly, at some point you guys told me or told that you have a new technique that eliminates brain shift somehow. Is that worth talking about, or that you don't seem to have much brain shift anymore?
Um, okay, so just try and get to the bottom of the question. I think the commonest failure of DBS is wrong patient selection at the end of the day,
Okay.
right? I think the problem is, and we're still learning. Sometimes it's wrong patient selection because we don't understand what was wrong about that particular
Yeah.
patient. I think it's really important to continue emphasizing, it's all very nice when everything goes right, and it's important to look at those patients, but it's really important to look at what happens when things go wrong or don't go the way you'd like them to go. And, I'd be the first one to say there are some patients where the electrode is spot on. It's bang on the anatomical
Yeah.
target. I couldn't draw it in a better position. And yet the patient isn't doing as well as I would like them to do.
Yeah. Yeah.
And the right thing to do there is to question, to speak with the patient, to talk about how else you can improve things. So just out of the top of my head, there are some patients, perfectly placed STN leads, fantastic result on all their symptoms, but you just can't get on top of their tremor. You just can't. And you try the high frequency and you try all the tricks and you try and go on the top contact. Just go. And what I've urged my neurologist to do is now bring these people back to clinic. Let's have a look at them. And I have a few patients where we've actually done a thalamotomy on top of the STN-DBS, and they're very happy. Why does this happen? I don't know.
Yeah. Yeah. Sure.
And other
Makes sense.
strategies are sometimes put a second pair of DBS leads in. So again, another patient that comes to mind, a young lady with STN-DBS, perfectly placed leads, just not doing the way we would like. We added another two STN-DBS leads more anteriorly within the STN, and her leads are within the anterior third of the visible STN. We normally talk about being in the posterior half. We switched the old ones off, and she's doing brilliantly with the anterior ones switched on. Why? I don't know. I
Yeah.
really don't know. But the important thing is not to give up on them because
Yeah.
these sweet spots are theoretical sweet spots. In terms of hidden, coming back to your brain shift thing, I think we always forget that at the end of the day, what we care about is the end result in terms of accuracy. Where is my arrow in relation to the target,
Yeah.
right? What led to that error is probably multifactorial. So coming back to the archer, you might have your bow sights might not be perfect. There may be a wind coming from the side. The feathers on your arrow may not be perfect.
Yeah.
And they
Yeah.
all add up together to give you this error. But if you have a systematic error, if you go up to your target board and most of your arrows are to the right, well, sometimes you just got to be pragmatic and don't aim at the center, aim
Yeah.
slightly to the left.
Yes.
And this is what we end up doing in DBS. So what we've noticed is that if we aim for a target, when we look at where the leads are, they're always slightly posterior and medial to where we want them to be. Now, I think one of the things that contributes to this is that the brain is not a piece of wood. The
Yeah.
brain is gelatinous. So as we pass through the brain with our probe, we're actually pushing the brain slightly as we go through the bone, even if there's no CSF leak, right?
Yeah.
Even if there's no air inside. So if you imagine your target being down here, by the time you've reached that, because you've pushed the brain down a
Yeah.
little,
Yeah.
you end up, because you're coming from that, slightly posterior and medial. And Andy, if you speak to people who do microarray recording, very often they use three trajectories, and they tend to choose a central track, an anterior track, and a lateral track. And I think this is why. So people who do microarray recording are trying to correct for the error But we do it in a slightly different way. Rather than do 3 tracks, we predict that we're going to be slightly posterior median. We have an algorithm based on the thousands of patients that we've operated on before, and we make micro adjustments of 0.5 or 1 millimeter in all of the 3 dimensions. And now our accuracy is trending at about 0.8 plus or minus 0.3 millimeters. So the
Wow.
standard deviation is about 1.4, which means 95% of our electrodes are within 1.4 millimeters of where we want them to be with a single pass. Now, that means that in 5% of patients, they're more than 1.4. And again, we don't just look at distance; we look at direction. So if you're 1.4 millimeters straight towards the capsule in the STN, then we will relocate it. Anything less than 1.5, I find very difficult to relocate because the electrode itself has a diameter of
Of course.
1.3, right?
Yeah.
But I will definitely not accept anything over 2 millimeters. Most times we change them if they're more than 1.5 millimeters away from where we want them to be. And it's so simple to do. It's another 20 minutes because the frame is still on, the
Yeah.
wound, you open it up and you move it around. Do all our patients do well? No. No therapy has a 100% success rate. But we try and approach it as much as possible.
I love that you can point these numbers, from the top of your head and know about them. I don't think many services would be that well organized to check, as you say, right? To check the archer's result that meticulously and know the
And it's
numbers.
the only thing we have, right? Because that imaging is it. We don't have
True.
microelectrode. We don't have clinic. We don't have
Yeah.
testing. All we have are our neurologists to keep us honest and our nurses to keep us honest,
Yeah.
and the imaging.
But the closing the loop via the neurologist and the nurses is absolutely important, but will not be that case specific, maybe, right? It's not as immediate. It would be more this, general. Of course, so I always, I love how you're doing it. It's all I want to say. So
I must make a plug. I must make a plug for Marie here because Marie's really brought a beautiful thing to us. You're saying closing the loop via the neurologist and the nurses. Marie actually does a complex clinic with one of our neurologists and one of our nurses, where they bring patients who aren't doing that well, and together with Marie, who does the image guided programming, they go through everything with that patient to try and optimize imaging. And for me, this is a really important service that they do because the old adage is 20% of your patients take 80% of your time, right? Because 80% are really easy. You turn on the DBS, off you go, bye-bye, you never see them again, right? Or they're doing really well. But those 20% patients keep coming back and you want to tweak them and you tweak them, they're doing well, they go away and they come back again. So at this complex clinic, those 20% of patients actually have a whole morning, or sometimes even a whole day, to optimize the stimulation. And we know that at this point, we either get it right, or we say, look, no more optimizing, come back to the surgical clinic and let's talk about whether further surgery will help, or whether we need to think about other things like advanced therapies, I don't know, duodopa or pro-duodopa, whatever it is, rather than these patients just coming back to our nurses and neurologists time after time and actually never getting anywhere. Sometimes you need that closure. So I think that's really important for us to understand. This isn't a perfect therapy, but we shouldn't give up on those patients. We shouldn't ignore them. We should really pay attention to how can we might not be able to help you that much, but maybe we can help you this much with something else.
Fantastic. And I remember Marie, who also was on the show before, she used to do all the programming or a lot of the programming in Switzerland.
Yeah, absolutely.
Do you also sometimes program, or have you in the past? Or
so when the service was smaller, it was really important, and I ended up doing the programming. For me, that was a really important part of my training as a functional neurosurgeon to understand the side effects and the effects during the surgery. And I'm doing a lot of radio frequency ablation these days, and those programming days were really important for me interpreting the intraoperative. Because unfortunately, our neurologists don't come to theatre. I say unfortunately, but we are our own neurologists during theatre, and we're very pleased that they trust us with that. And I think it can be difficult because the throughput. When I started operating with Marwan, we were doing 20 or 30 DBS procedures a year. which gave me the time to look at each patient in huge detail.
Sure.
We're now doing, 100, 120 DBS a year,
Oh, wow,
plus
that's a lot.
frequency ablation, plus the focused ultrasound, plus I have other hats on like my MVD practice, etc. So it is not possible for me to program.
Of course.
And
Yeah,
we have a small army of fantastic specialist nurses who look after the thousands of patients who are out there in the community. But I still think it's really important, even when you're changing a battery, to understand the settings and the stimulation settings.
Yeah.
And when I go to Malta, the neurologists there are fantastic, but they don't have as much experience as my neurologists here. So being able and being aware of all these programming strategies is really important when it comes to being part of that team. So I don't do it routinely, but I always urge my trainees to say, listen, okay, now you know how to do the surgery, you know how to do the planning. Now go away and spend 2 weeks with the nurses troubleshooting the programming of patients, because you won't be a good functional neurosurgeon unless you understand how what you're doing in theatre is translating to the therapy itself, because the therapy is not the surgery, the therapy is the electricity, right?
Yeah. Like the combination of both, right? Yeah, the
Well, you can't do the
electricity
electricity without the
work,
surgery, but
yeah.
switch it off and it's useless.
Yeah. Okay, fantastic. And then, do you think, like switching gears a bit, do you think closed loop DBS is the future?
So I think it's clearly going to play an important role in the future. Whether it is the future is another matter. I still think we haven't cracked it quite yet. Our neurologists are very excited about it and they're very positive about it. I think one of the issues is actually measuring what we're actually giving these patients. And I mean, if you look at the paper on adaptive closed loop DBS, the numbers are a little bit soft, if you ask me.
Yes.
But life is soft, and soft things are important in life too. And the question is, how can we use the scientific method to explore this? And it makes sense in the sense that, you don't need to have stimulation at the same setting all the time because the medication's oscillating. So there's clearly a rationale behind this. But then the flip side is the signal really everything that does it encompass the whole of the pathology of Parkinson's disease? And I'm not sure that it does. And how good is the pathological signals that we're picking up from other diseases, whether that's dystonia or OCD or whatever it is? Clearly very exciting, clearly academically very interesting. But we still use a mixture of closed loop systems that don't have closed loop and legacy patients that don't have closed loop. I don't see huge differences. I think there can be important differences in individual patients. But like I say again, I think it's important to push the boundaries of what we're doing, but also to I would like to see much more of a push of how we can streamline the process and bring this therapy to more patients. I think that's even more important than trying to refine, something that's actually pretty good already.
Yes.
It's the law of diminishing returns. Now we've got it. We've got adaptive closed loop. I think it's really nice that we're doing it. I think there's a huge amount of publications and scientific interest in that. Maybe the hardware needs to evolve a little bit more, and I don't want to make this more complex at all. But just to speak about a different approach to this, we've been using platinum iridium electrodes for many, many, many years. There's a product called graphene where you have much less impedance with the neural interface. When you have that less impedance, now you can have better temporal discrimination, you have better spatial discrimination, and maybe this is what we need to improve our recording of abnormal pathological signals in different disease states and improve our delivery of electricity. So maybe that's the next evolution. I don't know, but clearly adaptive closed loop DBS is here to stay. Whether it's going to kill closed loop DBS or sorry, open loop DBS is another matter.
Fantastic. So I had Patricia Limousin, who you mentioned on the show, and she told me recounted this episode where she switched on for the first time the bilateral STN DBS patient back in the day in Grenoble, and all of a sudden the patient stood up and walked, and that was very hard to believe. And we had Pierre Polack also on the show telling the same story from his perspective. He was in the next in a different room and then was rushed in by her to see the miracle. Both episodes really worth a listen, maybe for the listeners as well. But she also then mentioned as kind of a second biggest eureka moment in her career was actually a patient that you guys did in London together with ALIC DBS, with OCD, who apparently typically took long hours in the morning to get ready and get even out of bed, if I remember correctly. But the day after surgery, she came in and the patient was already dressed and the hair was made or whatever, right? So the big shift in personality, or in behavior at least, not personality, but that was apparently very impressive for her. And I think we also once sat, while you were doing this trial, once sat together somewhere. It might have been in Berlin together with Andrea Kuhn, where you also told us that, fixing tremor is one thing, but maybe changing this behavior of a patient in a good way, that really gives you goosebumps. I hope I'm quoting you correctly. It's been a long time, but maybe you can talk a bit about your experience in general with OCD DBS and that trial as well, if you want, and anything you want to talk about in that realm. Yeah.
I mean, let's face it, again, the brain is a fascinating thing. And when things go wrong, they can have fascinating pathology as a result. And whether it's tremor, and you talk about goosebumps, I still operate on people with tremor. And after 20 years, I still get goosebumps. It's just an amazing feelings and amazing, and it is hugely emotional. And patients that only this week we had a chap who was crying on the operating table, remembering this was his second side that we did a thalamotomy on, and he was saying, it was so nice. I wrote a love letter to my wife after my first side, and I told her, well, now you're gonna have to do it with your left hand as well. And you see this construction worker, big, massive tattoos all over, just reduced to tears and looking at his hand in wonder because the tremor's gone. It's an amazing privilege to be able to do that. But as you rightly said, OCD is just a fascinating disease, and so incapacitating. And how this disorder, which is not a degenerative disorder, that's the other exciting thing about it, right? How this can totally take an individual and a family and destroy their lives is just soul destroying to watch, right?
Yeah.
We have OCD in the family, so I've seen this close hands, right? And as Patricia rightly says, to be able to block that obsessive thought, to be able to reduce the anxiety, to be able to reduce that something that is blocking. You talked about the personality, but this disease is blocking the personality of the person from showing. It's truly, it's almost like you have somebody who's buried for years or for decades, and you've let them out of their coffin, right? Because they haven't self-imposed. It is an amazing moment. It's a totally amazing moment. And to be able to help people in that way is phenomenal. Now, I think we've only just scratched the surface when it comes to OCD. And I have a particular interest in mental health just because there is this division of psychiatry versus neurology, and psychiatry is just neurology with the higher functions of the brain, right?
Yeah.
And I'm just fascinated by the biological aspect of psychiatric disease, the social aspect of psychiatric disease, and how the two interact. Now, clearly, as a neurosurgeon, I'm more driven by the biological aspect. I can't change the social aspect. I wish I could. But teasing that out is very important. So this is where patient selection comes in. So yes, I think movement disorders is a very rewarding place to work in. But mental health is also extremely rewarding, and I think an eye opener. So to come back to the study, again, it was a collaboration between neurologists and neurosurgeons and neurophysiologists and psychiatrists and mental health nurses across the whole country. And I love that aspect of collaboration. And perhaps one of the things that blew me away, not just about the patients, but about the science behind it, is that that particular trial, the question that was outstanding for us when we came to this and said, what are the questions, was we had the STN being pushed by the French group. We had the ventral capsule being sort of the more traditional target coming from capsulotomy and lots of other groups. So we said, well, which target is better? So each patient actually had 4 of these electrodes put in. And in a blinded fashion, we tested the different electrodes. And lo and behold, there was no difference in terms of the improvement in OCD symptoms. But when we were stimulating the capsule, mood improved significantly, but didn't improve when we stimulated the STN. And the flip side was that cognitive rigidity, which is perhaps one of the defining things of OCD, where you the ability to change your mind with different evidence, right? That is high in patients with OCD, and that's improved with the STN DBS, but not with the VC
Yes.
DBS. So with just 6 patients, and these were big differences. We're not talking about small differences.
Yeah, yeah,
Big
yeah.
differences in every single patient. So in this one trial, we've kind of already changed how we think about the circuitry of the brain, because now we have a circuit that's driving OCD where the STN and the ventral capsule are on that circuit and nodes on that circuit. But then we have another circuit that regulates our mood where the ventral capsule is on it, but the STN doesn't appear to be on it,
Yeah.
at least in these OCD patients. Whereas another one where the STN appears to be on this circuit that allows us to assess evidence and change our mind about something, but the ventral capsule isn't on that. And when you look at the anatomy, and we've done lots of imaging studies, when you look at the connectivity of the various cortical areas, it kind of makes sense why this should
Yes.
happen. So
Yeah, yeah, yeah.
it's just amazing that we were able in such a small study really to tease that out. I mean, the other take-home message is that despite a huge improvement in OCD symptoms, the number of patients whose quality of life improved long term wasn't that great. So maybe 2 or 3 patients have really benefited in terms of quality of life, and they were learning things from that too. And I'm looking forward to the long-term outcome of these patients being published at some point. But one of them is the fact that they had OCD for decades. And
Yes.
once you can improve those symptoms, but once you've lost life's opportunity of education, of
Yes.
family building, well, sometimes you've lost it.
Yeah, yeah.
Um, Now, not all those patients, some of those patients took that improvement and actually ran with it. So,
Yeah.
bizarrely, one of the patients whose improvement was still very significant, but not the greatest, had actually the best quality of life because she
Oh,
took that opportunity and she's made the most of her life, and she traveled around the world and sends postcards from the back and beyond. And
oh, wow.
it's delightful to see her. This is a lady who couldn't leave her room for 6 years prior to the trial. But I think there's a lot for us to learn about this. We shouldn't be thinking about surgery as a last resort when patients' lives have completely fallen apart. And I often tell my psychiatry colleagues whenever I speak about neurosurgery for psychiatry, it's not about the surgery. It's about you have to think as a psychiatrist, right? In the next 2 years, I've got to make sure that I throw the book at this person from a non-surgical point of view. So if they're refractory, we can think about doing surgery, which has a 60% chance of improvement. But if you leave it 10 years before you think about neurosurgery, well, even if neurosurgery works, then what's the point from a personal point of view?
Yeah, it's a really good point you're making there. And I want to quote Helen Mayberg, who was actually episode 2 on the podcast, so one of the very first ones. And she said, she often tells patients, I can fix your depression, but I can't fix your life. That's the same thing with depression, right? If they had 20
Totally.
years of suffering, their life has so much revolved around this disorder,
Of
right? And has
course.
been incapacitated by it. So that's a really powerful thought you just brought up, that you essentially have to move quickly in a way as well, right? Like at least in terms of years.
Yeah, and again, mental health services are dreadful in the UK at the moment because they're often
Mm,
lacking resources the worst. So, people don't come to surgery because people don't even think about it. But even if they think about it, very often they haven't received the right therapy or a comprehensive therapy. So if we can use neurosurgery to focus the mind,
yeah.
David Christmas and Keith Matthews We're psychiatrists that we work with in Dundee. And very often I'd say, if we have 10 patients referred to for surgery, actually, we can sort 8 of them out by non-surgical means just because we are so focused on making sure that they've tried everything before they do the neurosurgery. So having a neurosurgical service isn't all about the numbers coming through neurosurgery. It's the number of patients who are referred for neurosurgery where we think really carefully before going ahead.
Despite the strong evidence supporting its use in the large numbers of individuals with, severe refractory OCD, you still receive very few referrals. This is a quote from you from an email, right? For consideration of neurosurgery. I think that's a global phenomenon. Same in Germany, and so for example, I could count the active DBS psychiatrists on one hand in Germany. I would say so. This is a huge problem. I think we probably both agree. Why is that? And do you have any ideas what could be done here? And then also maybe you can talk a bit about how many cases do you roughly do after this trial now? Is it still active? And
Yeah. So let's start from the first questions that you say. Why is it? I think it's multifactorial, right? I think number one, psychiatrists don't tend to work in the same place as neurosurgeons, so we don't talk. It's a bit like neurosurgeons and neurologists. We're in the same place, so you can talk and you can see how you can help each other. So the physical co-location is an important thing, which should be better with the technology that we're using at the moment, but isn't really the same thing, Andy. You know that having a beer and having a chat is really important. There's the legacy of neurosurgery. There's this problem with old lobotomy literature. Again, it's not something that should be unsurmountable. Something that I didn't think of until a recent meeting where one of the psychiatrists from UMIA made a really good point. And she was saying, neurosurgery for psychiatry is a footnote in our textbooks. It's a footnote in our lives. They are so incredibly busy, right? The energy that's required to think about neurosurgery and go through neurosurgical pathways, it is almost impossible for a jobbing psychiatrist to carve out some time to be able to do that. So one of the things we're trying to do at Queen Square is we have a professor of psychiatry who's interested in this, and we're trying to carve out one day a month for him to review patients who have failed ECT, because we think that's a good sort of throughput of depression.
Yeah.
We just talk about depression. But, one day a month isn't much. You've got to spend a long time with these patients, and the chances are he'll see maybe 2 patients if he's lucky in that one day, right? Because it takes a long time to go through the notes and all of that, and maybe both of them haven't tried the third high dose tricyclic or whatever it might be, so they never end up going to neurosurgery anyway. So the time that psychiatrists have is very, very difficult. And then a little bugbear of mine is that DBS is really difficult in patients with mental health conditions. Much more difficult than movement disorders. And I would put it to you, Andy, I mean, you've had neurology training. When you're dealing with patients, it's not the movement disorder patients that creates the problem, it's the psychological issues. Now, when the primary problem is the mental health aspect, even when they do well, if you have DBS, life is life. Life is difficult for these patients, and they expect the DBS to sort it out for them. And they will keep coming back for tweaks rather than actually taking their lives into their own hands and trying to make the best. I'm not saying they all do that, but it's a temptation. So I am very vociferous about the unsuitability of DBS for mental health, and the fact that we should be thinking about lesioning for mental health, for the simple reason that it makes follow-up much easier. The simple reason that the outcomes of lesioning versus DBS in trials are very similar. In fact, sometimes lesioning is safer and more effective. But again, we have to overcome that barrier of psychiatrists not thinking that this is a lobotomy, right? Which it isn't. And there is sometimes a discrimination. We talk about not discriminating against people with mental health, but we're very happy to whip out somebody's temporal lobe for epilepsy, but we're not
Mm.
happy to do a tiny capsulotomy for severe refractory OCD. And so for me,
Makes
that's
no
almost a
sense.
form of
Yeah, yeah,
discrimination. So again, what's the solution? I think education is the solution to everything in
yeah.
this
Mm.
world, isn't it? So again, I'm really fortunate that I share an office with a psychiatrist who specialized in OCD. Very really lucky that I work with a psychiatrist who leads the psychiatry department in Malta, and is very open to this. In fact, we're preparing a paper for publication on our experience of neurosurgery for OCD in Malta, having introduced the service there. And I go to conferences. So rather than just going to neurosurgery conferences and preaching to the converted, because every functional neurosurgeon wants to do mental health, I'm going to psychiatry conferences and talking to them and trying reaching out.
That's great.
You asked about the numbers, fingers of one hand, if that, in terms of throughput in a year. And it may not be me who sees the revolution. It may be, as we're talking about, the legacy that of people of neurosurgeons that come after me. All I can do is try and push the field forward, and maybe with the new generation of psychiatrists who are neuropsychiatrists rather than just psychiatrists, they will understand that we need more collaboration.
Yeah. Yeah. I mean, my own theory sometimes is also that, when we all go to med school, there's a certain fraction of us that will go into psychiatry, and that's a selection bias, right? They might sometimes be, on average, more selected to not be as somatically minded. Maybe the brain is not automatically their key interest. But then, of course, there are these more biological psychiatrists that go for it exactly for that reason, right? I would have loved to go into psychiatry actually, but from a neuroscience kind of perspective. But that might be the minority of psychiatrists, and so I wonder sometimes whether that is just a selection bias of people that might not be interested in DBS. But then I think against that speaks the TMS successes they have, right? This is where they do neuromodulation and quite brain stimulation a lot. So it's a complex topic. We probably can't solve it, as you say, but.
I think it's changing. I think more and more younger people are going into psychiatry because they're interested in the brain. But the
Yeah.
truth of the matter is, and we'll come back to this, society is quite cruel these days. And when you have the huge wealth inequality that we have, where you have some individuals owning millions or billions of pounds, and others scraping together to find a meal for their children, and going hungry and not knowing if they're going to be able to afford the roof over their head. I mean, we all have breaking points, and I think that we need to be a little bit more humane towards each other, and I think. Yeah, this is the vast majority of what psychiatrists have to deal with, and that's why they're less interested in the brain and more interested in the social aspects or the behavioral modification, because that is the driving force behind most of mental health issues in
Yeah.
today's world.
You have mentioned lesioning just now. That might be a better avenue for psychiatric disorders. Maybe exactly for the reason that it's a one and done deal. There's no indwelling hardware. There's not as many tweaks that need to be done, can be done. Can you talk about that? But then also, if you want, talk about DBS versus lesioning more generally. I know you have an MR-guided focused ultrasound system now since a few years. How was the experience? How do you think of the two approaches
Yeah.
in psych and movement disorders?
So Andy, I'll take it back to you. Why do we do DBS in movement disorders? And the only reason we do DBS for movement disorders is not efficacy. It's side effects, right? If you go back to why the DBS was done, it was done contralateral to a thalamotomy because they were worried about doing a lesion on the contralateral side, right?
Yeah.
Why do we do STN DBS? It's because they were worried about causing hemibilismus because we knew that a stroke in the subthalamic region could cause hemibilismus. Even if you look at the only trial comparing DBS versus lesioning, where Rick Sherman was a junior author on that, this was a ventriculography-based paper. If you look at the long-term outcome published from that, the lesioning group were doing better than the DBS group. But the side effects were greater in the lesioning group. And that's clear. If you're not in the right target and you lesion the wrong target, well, you can't switch it off.
Mm.
right? So the lesions are going to have a higher risk factor, even on a unilateral. So
Yeah.
I think the beauty of MR guided focused ultrasound is that it's made us think about lesioning again, right? It's made it acceptable. And
Yeah.
this is, of course, it's sexy. You put two great technologies. We like this. We're grown men, but we're boys with toys, right? And if you've got a £2 million machine to play around with, and having one, it's spectacular. The
Yeah.
fact you can do what we talked about doing without having to get your hands dirty, without having to drill a hole in somebody's head. It is truly a miracle of scientific science and technology to wed these two technologies together and to be able to make a lesion in the brain that improves symptoms. It's wonderful, absolutely wonderful. Um, but again, hats off to Marwan, who thankfully was young enough to do DBS and old enough to have done radiofrequency ablation. And I think that the lessons that we've learned in terms of improving imaging quality, in terms of improving targeting accuracy, in terms of understanding the radiological anatomy, are really well placed for successful MR first, but also for reintroducing, if you like, RF lesioning. So when it comes to mental health disorders, I just think lesions are having a minor experience in both DBS and lesions. I just think lesions are easier for the patient and the psychiatrist to deal with,
Yeah.
and the results seem just as good. Um, and when it comes to movement disorders, I think having DBS is not going to go away by any stretch of the imagination. But I think there are some patients who are really well served by a lesion. I mean, only
Yeah.
this very week, we had two patients in their mid-70s with Parkinson's disease and predominant tremor.
Mm.
STN, DBS, cognitive issues, follow-up,
Yeah. Yeah.
both extremely happy with a tiny, tiny lesion, well placed in a visualized VIM. So I think it's really nice that we have all of these tools at our disposal. I don't think, you have all these debates of is DBS better or is lesioning better or is it's irrelevant. I think
Yeah.
the ability to have all these tools and to discuss the pros and cons with each patient and to appropriately use the tool, and with experience, you will know what you can do with each tool, and then you can guide patients even more. Now, what's the evidence? You speak to Gunther Deutschel, who's completely against radiofrequency
Mm.
ablation. I suspect because he's had very bad, if a neurologist has a patient who doesn't do well, they won't send another patient for that therapy. And I completely
Mm.
understand, especially if they're worse off. But he very graciously came to London last year. It was lovely to speak with him, and he gifted me a wonderful book from Brand, which I was extremely um, delighted to receive. And he agrees that in certain patients, a radiofrequency ablation might be the right thing. So I'm quite vocal in trying to teach this because it's not just about the UK or Germany, but this is something that in Africa would be amazing. You're not going to
Yes.
do DBS in a country that can't afford it or that can't look after whether it's India, whether it's China, not because they're not affluent, but because of the distances that you may have to travel between one DBS center and where the patient lives. So yeah, I think it's not a competition. It's an extra tool, and we should embrace everything we have, including the focused ultrasound.
Just talked to Günther yesterday on the phone, and he, as you may know, planning a big trial with Fasten. Right. So there's a I admire him being so active and then
Okay.
also always open to new technology. I think he used to be, when MR came and all these things, and so he's a fantastic figure. So I'm glad you, had a good experience there together, and would love to see the book that you got. Love
Oh,
historical books.
it's in my office. Otherwise, I'd bring it to you.
Great. And then the we've been talking a long time. I want to be mindful of your time. And this must be tiring as well. So I want to close a bit with rapid fire questions. But one
Okay.
of the first of them is maybe not as rapid fire. But I just love to hear you say it. How does DBS work?
Oh, goodness. Okay, so how does it work? Clearly, we're disrupting information flow through a circuit. If we're disrupting information flow, then that information flow must be detrimental, right, for the brain to do better with it. If it's detrimental, why is the brain producing detrimental information, right? And it all comes back, my overarching theory, which is not just mine, is that the brain is an organ of prediction, and that's why it works well. And there are some pathologies that make the brain produce very strong but wrong predictions. The example I always give is if you're climbing the stairs in the middle of the night and you think there's an extra step and there isn't,
Yeah.
well, you're going to stumble and fall. If you're climbing the stairs in the middle of the night and I tell you, you don't know how many stairs there are, right? You're still going up gingerly now, not normally because it's dark, right? But you're not going to stumble and fall. So having no prediction or having a hazy prediction is better than having a strong prediction that's wrong. And I think that's what we're doing. Whether we're making a lesion, whether we're disrupting abnormal synchronization, and again, synchronization is the key here. I mean, how this brain works more and more, we know that it's how distant areas of the brain synchronize in terms of firing patterns. This is how the brain does what it does. And that's why it falls into abnormal synchronization circuits when there's pathology that disrupts these synchronizations. So, yeah, rapid fire, I'm not sure it's a very global philosophical argument, if you like, but that
Yeah.
is why I'm more skeptical about things like DBS or lesioning helping in Alzheimer's disease or dementia, because I don't see dementia as a disorder of prediction. I see it's a disorder of failing to produce memories, which then don't allow you to make accurate predictions. Because if you don't know what you've just done, how can you predict what's going to happen? So I don't see that as happening. But OCD fits that very nicely. My hands are dirty, right? If I don't clean them, something terrible is going to happen. So I wash them. I still make another abnormal prediction. My hands are dirty, right? Same
Yeah.
with movement, same with dystonia. Everything that has class one evidence that functional neurosurgery, whether it's lesional or DBS, works, you can couch in terms of this being an abnormal prediction model that we're disrupting.
I'm so happy you just said all of that because you had said it before to a very young Andy Horn, and it really changed my way of thinking fundamentally, right? So this is these both things, the prediction part, and then the even just the simple fact that we're disrupting information flow. It might not be obvious to people that enter the field, and the misnomer of stimulation might be at fault of that, right? For if you're a young PhD student, you wouldn't think like that. You would think, oh, we stimulate the brain, right?
Okay.
And I think it's so important that we should repeat it to especially the young people that enter the field that this is probably more true, and it's very important. It shapes the thinking. So thank you for saying that. Also maybe for younger listeners that may listen to this. Okay, so now more rapid fire if you want. How does the field of neuromodulation, or more specifically functional neurosurgery of the future look like?
That's a
What
very
will your
good.
theater look like?
Well, I think we're going to see more and more. I think movement disorder will still dominate the field. I'd like to think that we're doing more mental health disorders because I think we have the opportunity there. I think it will look like the fact that we are using multiple tools. I'd like to think that we do have access to all of these things and we should be using all of them. I really don't want to see, I hope I don't see centers that just have a focused ultrasound or centers that do deep brain stimulation and won't think of lesioning, right? And I think that would be, it'd be rather sad. Um, I think in terms of the throughput, we do need to treat more patients. We don't treat even half of the patients that would benefit from DBS, for example. So I think having an intraoperative CT scanner is probably really quite useful and to that, and doing more surgery asleep, I would say that. But I've seen the improvements in our own practice of doing a sleep deep brain stimulation. I do awake lesioning, right?
Yeah. Okay.
Whether I'll have the guts to do a sleep lesioning, I've done it on occasion for status dystonicus, for example, where you can't do them awake, and Pomodoro things like that with good effect. But I think I would do an asleep if the patient insisted on it lesioning because we've got our
Mm.
targeting down to a fine T. But still, I don't see the need. I think doing it awake is fine. But I think getting more patients through the door for me is a priority. But that's perhaps because of where I am within the NHS with such limited access to theatres, time and space.
You mentioned movement disorders will still dominate, so I want to inject a small additional question here. I just talked to Casey Halpern a few days ago, and he said that he thinks maybe depression will become much bigger. And he essentially said there's 500 million people affected by it in the States, and more like maybe 5 million or so that, or even 1 million of people that would profit for Parkinson's disease. Do you agree with that? Right? Could depression become much bigger?
Again, I think depression is a societal issue in the vast majority of things, and so of course there is biological depression. Of course there is, and I think biological depression is something that may need surgical intervention.
Mm,
But a lot of people who have depression are usually uh, in such terrible circumstances that
mm,
they've broken because of those circumstances. It reminds me a little bit of research in the States where they're trying to do DBS for post-traumatic stress disorder for 18-year-olds that they've sent to battle. I mean,
mm.
don't send them to war zones and then they won't have post-traumatic stress disorder. I mean, I think that's the answer to that. I don't think we should be fixing something that society is causing. So I tend to agree that we're not doing enough, definitely. I think there are loads of people with biological depression out there. And I think that's why the ECT clinics are perhaps a really good way of looking at people because the response to ECT is 50 to 60%.
Mm.
Thousands of people still undergo ECT, and despite the controversy in the lay press, it's a really good treatment
Of
for
course.
depression. A fantastic treatment for depression. We don't know how it works, but we often don't know how things work, or we have hypotheses that are then proved to be wrong. So I think I'll go halfway house on that with you with Casey, in the sense that yes, there's a huge number of people out there with depression, but I don't think all of them are going to be amenable or should be subjected to neurosurgical intervention. But I think enough of them are out there to make me not want to do deep brain stimulation and perhaps try and find an ablative procedure instead.
Got it. What were big eureka moments in your life,
We've talked
clinical
about
or scientific?
We've talked about the biggest eureka was my change in direction when I was a young kid, right?
Yeah.
And I think that came just to hark back to that. Um, I, I think people would talk to me, describe me as being quite extroverted now, quite talkative and quite friendly and whatnot. It's quite a bit more introverted when I was younger, and when I was in my physics and maths phase. And I think coming down the medical route has humanized me to a great degree. It's made me have to interact with people and has brought out or developed a side of me that might not have developed if I was buried in my equations for decades at a time. So I think that was a big eureka moment. I'm not sure that I've had that many. I mean, I've described the little turning points of, individual patients that don't do well, and then you change tack. I've already told you about how I've changed tack from vascular neurosurgery to pediatric, and then the eureka moment for my pediatrics was coming home after a weekend on call and for the first time in my life, not wanting to go to work the next day because I was so depressed about a kid that had died.
Mm.
And that for me was, yeah, maybe I'm not built for this.
Yeah, yeah.
Um, yeah, other than that, I'm really fortunate that I don't have any so far I don't have any regrets, which is a really nice position to be in life.
Any time where you thought this was a waste of my time or this didn't go so well? I mean, we've covered a few, and I think it's always, especially for the young people, good to talk about also the failures. And you've shared plenty
Yeah.
of things. Any other things you want to say there?
I would say that I would never consider anything a waste of time. Sometimes it takes you longer than you think it should have. you look back and you say, why didn't I realize that 3 years ago or 5 years ago or whatever time it was ago? And sometimes you just need that time. You need that time to readjust. And sometimes it is times of crisis. Sometimes it is times of where you question yourself. Oh my goodness, why am I doing this? Or what has happened here?
Mm.
That really make you reassess your position, make you take big decisions. But I never look back on it as a waste of time. That's just what had to happen in order to me to change course. And um, plug with it, and make the time. I think you talk about the younger thing. Make the time to be with yourself every week at least. Give yourself some time. Go for a walk. Have a long bath. Disconnect, and
Yeah.
ask yourself, is this really what I want to be doing? And if it isn't, make a change.
Any more general advice for people, young folks that want to enter, let's say, academic neurosurgery?
Um, I think you have to be a good neurosurgeon before you're a good academic neurosurgeon. And I think sometimes people do research early on in their career thinking this is what they want to be, and then they end up doing the neurosurgery and either not enjoying it or being so stressed by the surgical procedure.
Mm.
So I think it's really nice to have an academic mind, whatever it is. But before you start doing academic neurosurgery, first please become a good neurosurgeon, and then take the opportunities on the way to develop academic interests. Um, but very often you end up doing an MD, PhD, and then doing neurosurgery. And that's not a bad way forward at all. But
Mm.
sometimes, if you don't like the neurosurgical part, just admit it to yourself. Your PhD, even if it was on a neurosurgical topic, isn't going to be wasted.
Yes.
Choose something else to do with it. I had a very good friend who was a really good neurosurgical registrar. We were young registrars together, but he hated operating. He got so
Mhm.
stressed by it. He was a very good surgeon, and I think he agonized so much over what the implications of what he was doing. He ended up doing interventional neuroradiology, and he's a
Mhm.
really good interventional neuroradiologist now. So I think, it's good to have a goal, but I
Yeah.
think you shouldn't blinker yourself to the opportunities that present along the way. And certainly, functional neurosurgery is becoming less and less and less invasive. So, you might end up doing something which isn't neurosurgical, but still helping patients to a huge degree, or learning about the human brain in a much greater degree. Don't be
As
blinkered.
as a thank you. As a field, are there any missed opportunities, things we should be doing but are not doing enough?
Gosh, that's a big one.
I mean, you mentioned the NHS, right? So there's, I'm sure,
Oh,
probably a lot to talk about, but UK specific, but also maybe, yeah, anything
well,
you may think of.
as a species, we clearly don't. We spend far too much money on fighting each other and not
Mm,
collaborating with each other, and spending far
yes.
too much money on, instead of pumping money into scientific research. Well, we should have already got cold fusion right going, and this energy supplies shouldn't be a problem. Germany doing pretty well, I hear, on the cold fusion research front.
I'm not up to date there, so can't
But
comment.
this is crazy. I mean, we waste so much time navel gazing and so much time infighting when we
Yeah.
have all these bigger questions, whether it's climate change or energy production or whatever. And maybe, one looks at the politicians around the world, and these career politicians don't ever live a normal life. Very few of them actually have a scientific background and can think critically.
Mm,
And we've put a lot of money and a lot of power in the hands of very few people who clearly don't have the best interests of humanity at heart. And it all comes down to education. If we don't invest in our future and the education of our children, whether that's at primary school level, secondary school level, or university, and I'll come back to saying how proud I am of that little rock in the middle of the Mediterranean that I'm genetically from. that they actually pay their students to improve themselves and to go to university, that we're investing, that country's investing in its future, and how dreadful it is that we have a left-wing government and we put our students into hundreds of thousands of debt in the UK, and that the America, which is, one of the richest countries in the world, puts its students into thousands, hundreds of thousands of pounds of debt, and makes their career about killing that debt rather than thinking about something other than money. I mean, we've put money at the center of our society for far too long. And here's me becoming all philosophical.
Love it. Yeah, no. I mean, 100% agree with everything you said. And the military budgets dwarf the scientific budgets, right? So, yeah, by far. Yeah. Is there any topic you would have loved to discuss that I missed?
Oh gosh, Andy, I could sit here and talk forever about anything with you.
But I've covered a lot and took a lot of your time. So
no, we've covered a lot, and I've enjoyed the time I've spent with you very much. I don't think there's anything that springs to mind, to be honest. But maybe we should do this in person at some point.
We love that with a beer. Yeah. So as I mentioned, I did reach out to your colleagues, right? Harith, Marwan, Marie, but also Himanshu Tyagi, and in questions I should ask. And I just want to share that the main sentiment they all kind of shared was that you might be much better than you think you are, or like greater than for the world than you think you are. And I really agree. You're a fantastic colleague, very insightful, speaker, scientist, and I'm sure you're also a great surgeon. I cannot really judge that, of course, but it's really a big honor. It's been a big honor to talk to you, and thank you for taking so much time out of your busy day. And
pleasure's all mine, Andy. Thank you so much for the feedback. And I'll say it again, I think I just am so fortunate to work with such a fantastic group of people, and to fraternize with international colleagues such as yourself. So, Andy, until we meet again, I look forward to the next meeting.
Thanks so much.
Take care, buddy.